Okay.
Your presentation, sir. Start now.
Okay. Respected chairpersons, distinguished panelists and participants, Assalamu alaikum. Today's my topic is single versus double stent in left main distal PCI. Left main coronary artery disease is the highest risk lesion subset of ischemic heart disease due to its high morbidity and mortality. PCI to left main distal lesion is still one of the most challenging tasks for interventional cardiologists. Now, according to the location, there are around 70 to 80% of the left main lesion is in the distal portion. Now, why PCI in left main bifurcation is risky? There is chance of abrupt closure and stent thrombosis is high. Chance of flap shifting and closure of the side branch. Chance of restenosis is high. And chance of strut fracture, dissection and perforation is high. Difficult to have perfect lumen reconstruction and chance of incomplete coverage. Why the left main bifurcation PCI is challenging? There is a vessel shape and sizing. There is a distribution in the diameter between the proximal and distal reference, and procedural complication like flap shifting, dissection, and perforation is common, and variation in the bifurcation and lesion anatomy. The side branch patency, plaque distribution pattern, lesion comparison, angle between main branch, and so all should be counted. Now there is a classification of the bifurcation lesion, and there is a lot of classification, but Medina classification is well accepted. Here is the true bifurcation lesion is the 111 and 0111. Approach to the left main PCI, there is approach true or non-true bifurcated lesion, side of the side branch, extent and distribution of the disease in side branch, how important the side branch is for that patient and for that specific anatomy, angle from the main branch. And this is the one of the algorithm, that is where the strategy. First of all, the side branch need to be preserved. If there is no need to preserve the side branch, that is show single stent strategy should be accepted here. And if the side branch should be preserved, then it is a provisional chance of occlusion is low, then it should be taken as the provisional stenting strategy, and the side branch occlusion is chance is high, then directly to stent strategy. In provisional stenting strategy, wiring of the side branch was done and crossover stenting was done. If the side branch is not compromised, then procedure is completed here. If the side branch is completed, then rewiring should be done and balloon angioplasty. And after doing balloon angioplasty, if the successfully the TME3 fluid achieved, then procedure will be stopped here. And if it is failed, then we go to the second stent should be added. And in case of two-stent, there is a strategy. In case of provisional stenting strategy, the angulation, if the 70 to 90 degree, then tap should be choice, and if the less than 70 degree, then reverse cut and pull out. In case of directly two-stent strategy, if the angle between the 70 to 90 degree, there is T-stent and tap, and here the less than 70 degree decay crash and pull out is the choice. Strategy of the left main bifurcation, already I stated the provisional stenting and two-stent strategy. Provisional stenting is simple and fast, excellent short-term and long-term results, better long-term mortality, reserves all other options. That is, if needed, balloon angioplasty and two-stent can be added. 70 to 80% patients with left main bifurcation can be treated with using the provisional technique. And which lesions are suited for the provisional stenting? Insignificant stenosis at the Ostial LCX and Medina classification 110 or 100. Small LCX that is less than 2.5 millimeter diameter, non-dominant LCX, wide angle between the LAD and LCX, no concomitant disease or only focal disease in LCX. Here is a case for the provisional stenting. There is a left system showing the significant distal left main disease with significant lesions involving the proximal and mid segment of the LAD. And after wiring of the LAD and LCX, distal left main and proximal LED was dilated. Then the position of the stent and from left main to LED, and deployment of the stent done. And the final results that the LCX is not compromised, sidebands is not compromised, and final result. This is the provisional stenting technique. Here only single stenting is used for this procedure. There is several trials which shows that the provisional stenting is initially there is superior than the two-stenting stages. There is Nordic trial, Cactus trials, Colombo et al. All showing that the MACE and the target lesion regression all are less needed in the provisional stenting strategy. That is for coronary bifurcation lesion, provisional stent, single stent approach appears to be associated with lower long-term mortality than a systematic dual stenting technique. Meta-analysis also shows for the support for the provisional single stenting technique initially, but now the definition trial which shows that shows the lower periprocedial MI and cardiac death. Here, there shows the target lesion revascularization is more in case of the provisional stenting technique, and target vessel MI also more in case of provisional stenting technique. And provisional stent technique, as already I mentioned, there is a step-by-step technique. There is insertion of the wire in both branch. Then after doing deployment of the stent, if needed, rewiring can be done, and gel wire is drained carefully to avoid abrupt guiding catheter intubation, and subsequently advance into the distal left main basin. Kissing balloon inflation is carried out with 2 short balloons, preferably non-compliant with a diameter compatible with both distal branches. How often do you need a second stent? Colombo et al. Shows that around 30% cases needed second stent, but others like Penn et al. And Stenting shows the lesser number of second stent needed in case of provisional stenting strategy. Sidebands stenting, which is needed. There is significant sidebands flow impairment that is less than TIMI grade 3 in the presence of a major band sidebands dissection when the sidebands is diseased and large enough to lead significant restoration, when future access towards the sidebands may be important. When provisional requiring the second stent bailout procedure, in case of TAP already I mentioned, and reverse cuts and pull-out technique, and in case of TAP is easy to perform, but disadvantage is it starts protruding into the main branch chance. And in case of pull-out, there is a more difficult rewiring, difference branches, double stent layer. Two-stent strategy, there is double stenting needed in 15 to 30% to achieve an optimal angiography result in coronary bifurcation. There is, in case of significant stenosis at the ostial LCX with Medina 111, and LCX more than 2.5 millimeter, disease left dominant coronary system, narrow angle between the LAD and LCX. Which already I mentioned, there is pull-out T-stent technique. In case pull-out is the choice when the side branch and my main vessel is the same diameter, and T-stenting and decay crash if the side branch is less than main vessels and angle less than 90 degree. Double stent already I mentioned that if the angle is more than 70 degree, then T-stenting and tapping is the technique is the suitable, and less than 70 degree pull-out crash technique, decay crash technique is suitable. Now is the case that there is a decay crash technique. Here the lesion is 111. There is complex left main bifurcation lesion. Then in first stage, the wiring of the both main vessel and side branch vessel, and there is the balloon in the main branch, and at first we deployed the stent in the side branch. Then we crushed the side branch stent by the balloon in the main branch vessel. Then first rewiring is done through the crushed stent. Then first kissing balloon inflammation was done to the main branch vessel and side branch vessel. Then stenting in the left main to LAD was done. Then first pot is done. Then second rewiring is done through the main vessel stent into the side branch. The final kissing balloon inflation was done, and final port was done, and this is the final result. Imaging support is needed in case of left main distal bifurcation lesion. IVAS or OCT can provide essential information for assessment and treatment. They provide a better insight into plaque configuration and can diminish the unnecessary use of two-stent procedure by identifying the extent of disease. This may improve outcomes and allow selection of an appropriate stenting strategy. Imaging may aid in vessel sizing and identified calcification that may need atherectomy. And angiography sometimes misleading the severity of the lesion. In case of among 73 lesions with 75% stenosis, only 20%, that is around 27.4% lesions functionally significant. So FFR assessment will be helped for strategy, decision taking whether two-stent or provisional single stent strategy. That is, Malady et al. Shows in case of left main bifurcation lesions, that is reversibilation based on FFR was safe. Conclusion, the goal of PCI in left main bifurcation lesion is to attain optimal results in terms of maintain physiologic patency of the side branch. Planning of the strategy upfront in critical, and knowledge of all possible bailout techniques must be kept in mind. While provisional sideband stenting should be the default technique for low risk bifurcation, two-stent technique may be preferable for high risk or true bifurcation. Although evidence is lacking as to the superiority of one two-stent technique versus others, it is unlikely that any single two-stent technique would be superior in all bifurcation morphologies. The decay crash technique seems to be most favorable, but tap and pull-out techniques are also excellent option. The decision as to which two-stent techniques to use should be driven by bifurcation morphology, operator experience, and clinical trial data. Employ imaging and atherectomy to save time and optimal outcomes. Thank you very much.
Thank you so much, Professor Dr. Mamunur, sir, for your excellent presentation, and finish your presentation within time.